Generally, I'm focusing on melanoma and sarcomas, and in melanoma, the role of surgery was really changing over the years, and now I will focus how we individualize approach and how we reduce the extent of surgical intervention. Of course, the first step was introduction of the sentinel biopsy, which since 1999 was standard of care in melanoma patients, and it eliminated completely elective lymph node dissection. And still it's recommended. However, now even the debate about the utility of sentinel biopsy started. But the next step was based on two trials, MSLT-II and DeCOG-SLT, was elimination of complete lymph node dissection after positive sentinel lymph node biopsy. Because both of these trials confirmed that there is no impact on melanoma-specific survival in a patient with sentinel melanoma, and they do not have any significant benefit in survival or recurrence rate if they undergo completion lymph node dissection rather than observation. It has been also confirmed in several meta-analyses and also in some projects like matching analysis between the patients who had completion lymph node dissection after positive sentinel biopsy or just had the surveillance, the observation. Moreover, it seems that CLND, so completion lymph node dissection, does not improve survival. We know it, but also leads only to the change in disease stage in less than 6% of patients. So generally is not defensible now, and it was abolished, and generally CLND now is obsolete. This has been excluded from the major guidelines, including ESMO guidelines, Polish guidelines, and also ASCO guidelines. It's only the option for the patient who didn't want to have any adjuvant therapy or observation. However, generally patients with no adjuvant treatment should be followed up with ultrasound, but the patients receiving adjuvant therapy, which is now the standard of care as a systemic treatment for 1 year after positive sentinel lymph node, stage 3. So they have no additional benefit from ultrasound because they have cross-sectional imaging. Still, regional control is increased with sentinel biopsy, and even if adjuvant therapy, systemic adjuvant therapy, now it's approved for stage 2B and 2C melanoma, but still it is worth to know the exact prognosis of the patient, the relapse rate, and also in stage 3 we have extra one more option. Dabrafenib and trametinib is used in adjuvant therapy. Maybe in the nearest future, the tissue or genetic prognostic biomarkers will be introduced, and in this situation, gene expression profile risk classification, maybe they will replace sentinel node biopsy. But this is a future. We need the prospective trials, and generally even using this GEP systems, probably it's a complementary to sentinel node biopsy. So the next step after the surgery with undetectable, so non-palpable lymph nodes, the next step will be probably the reducing of therapeutic lymph node dissection, because still it is done for macroscopic, I mean palpable or radiologically detected lymph node metastasis. And CLND is, of course, related to significant morbidity. So now, because in these patients, neoadjuvant therapy is introduced before operation based on the SWOG trial and mainly NADINA trials of 2 cycles of ipi-nivo, it can lead to less extensive surgery also with palpable nodes. There was one trial, PRADO trial, which was focused on the reducing the extent of surgery in this situation. These patients had only index node, which was marked before the immunotherapy, and after immunotherapy, this index node was only removed. If in this index node was pathological complete remission or near pathological complete remission, the patient did not undergo the further therapeutic lymph node dissection. And the relapse-free survival and distance metastasis-free survival with the patients with major pathological response and therapeutic lymph node dissection omission was exactly the same like the patient after therapeutic lymph node dissection. So it is interesting option for the future, but again, we need further studies. Moreover, we have also the data that generally the treatment, the surgery after neoadjuvant therapy is not affected by neoadjuvant therapy, so it means that we haven't the increase of surgical complication in our patients. So the personalization with neoadjuvant therapy also goes probably for the less extensive surgery in the nearest future. So because in at least 60% of patients we have huge downstaging of the tumor, and the pathological response is important predictive factor. In the future, MSLT-III trial maybe will be performed, and it will be resolve this question about this adapting the strategy for lymph nodes for our patients. So the next step may be also the introducing the neoadjuvant therapy for stage 2 disease, but it's still too early. So this is generally what I wanted to summarize what I presented during the Dermato-Oncology European Congress 2024.